Yeah, it's a great question. So there have been some pretty compelling retrospective data that have shown that molecular subtypes of bladder cancer, like the basal subtype specifically, as well as the presence of DNA damage response or DDR gene alterations, are associated with sensitivity to cisplatin-based chemotherapy in bladder cancer. Um, and so one of these data sets was from a study of dose-dense MVAC, a four-drug regimen, with bevacizumab as preoperative therapy in patients who had muscle-invasive bladder cancer, and that was prior to cystectomy. And it showed that patients with the basal subtype had the best long-term sort of 5-year survival, especially when compared to those patients who had a different subtype, the P53 enriched subtype that had the lowest survival. And then there are data from a couple of institutions that have shown that mutations in specific DNA damage response genes, ERCC2 being the most common one, but also in genes like ATM and RB1 and FANC-C, have been associated now with heightened response to cisplatin-based chemotherapy. And all of that has really been specifically in patients who had earlier stage bladder cancer, so sort of stage 2 to stage 3 bladder cancer, where the goal is still to do surgery, a cystectomy to remove the bladder. And in those patients, what they found was that patients who really had those genetic mutations within those specific DNA damage response genes were the ones who were more likely to have a complete pathologic response at the time of surgery, where they really had no evidence of residual tumor within the bladder after the chemotherapy, indicating that those tumors were sort of had this heightened sensitivity to cisplatin-based chemotherapy. And so the idea was, well, if that's the case in that setting, in the sort of preoperative setting, do we see similar observations in patients who have more advanced or metastatic urothelial carcinoma? And then we were very lucky in that there was this large phase 3 clinical trial that had already been completed, which was gemcitabine and cisplatin versus gemcitabine, cisplatin, and bevacizumab in the metastatic setting, in the first line metastatic space. And so, luckily we had tissue from patients who had enrolled onto that study and wanted to see if a similar association was found in the metastatic setting as well. Yeah, so it is still possible that angiogenic signaling is important for basal tumors, especially since we do see at least a numerical improvement in progression-free survival in the patients who had basal tumors. But we really do lack the power in this cohort, at least, to tease that out further. About 15% of the tumors in this cohort just didn't have adequate RNA of sufficient quality for whole transcriptome sequencing. And additionally, in this cohort, basal tumors were also not associated with improved survival following cisplatin-based chemotherapy, and they also weren't enriched with angiogenesis signatures as well. And so that may indicate that the benefits of bevacizumab within the basal tumors might also be stemming from an alternative mechanism as opposed to an anti-angiogenic mechanism. So it's still very difficult to know for sure. In contrast to this study, there was another trial, the range trial, where basal tumors did seem to be enriched in those patients who had better responses to different anti-angiogenic therapy, ramucirumab with chemotherapy. But the difference there, one of the big differences was that they also had a much larger number of tumors where they could really try to tease out that difference. And with this, even though this was a large study, it still didn't have enough specimens to be able to do that. And also the number of tumors that were subtyped as basal was also substantially lower in this specific study. So I think with those limitations, it's hard to say for sure that there might not still be a benefit with bevacizumab and sort of an anti-angiogenic or enrichment for basal tumors within within those patients that have responses to anti-angiogenic therapy. It's just not a question that we were able to answer in this study, given the numbers. Yeah, so that was the other main finding from this study. One was looking at whether molecular subtypes like the basal subtype were associated with response. The other was our DDR gene alterations associated with response to platinum-based chemotherapy. And notably in this study, there wasn't really that association, as you mentioned. And there may be a lot of reasons for that discrepancy when we compare these observations to what we see in the neoadjuvant setting, where there clearly does seem to be a signal for improved efficacy of cisplatin-based chemotherapy in the patients whose tumors have DDR gene alterations. The big thing could be that the metastatic disease space is just fundamentally different biologically from the organ-confined space. And so we just may not be able to apply the same data and the same sort of biomarkers that we're identifying in the organ-confined space to the more advanced space setting. Also, the rates of DDR gene alterations in patients who have metastatic disease, where the metastatic lesion is sequenced, are just not that well defined. The urothelial TCGA, which is really the most comprehensive genomic and transcriptomic analysis of urothelial cancer to date, was restricted to muscle invasive bladder cancer and not metastatic specimens. And in this study too, archival specimens were sequenced, not the metastatic tissue. And although DDR gene alterations in general were detected in about half of the tumors in this cohort, and deleterious DDR gene alterations in about a fifth of this cohort, we still don't know though if those rates are reflective of what we see in the metastatic setting in when patients are actually enrolled onto the study. And in fact, other groups have already shown that there's a discordance both in terms of the molecular subtype between primary and metastatic disease, and also in terms of the genomic profiles as well between matched primary and metastatic specimens from the same patients. And also kind of along those lines, there's a separate publication that was related specifically to this same cohort, the CALGB 90601 cohort, that was led by Brendan Garcia, who's currently at the University of Rochester, where they looked at plasma specimens from these patients and specifically isolated circulating free DNA to see if there may be any association between DDR gene alterations and cisplatin-based chemotherapy response. They only found 24 specimens that actually had DDR gene alterations within that group, which again sort of underscores that perhaps the DDR gene alteration rate might be much lower in the metastatic space. And so we just may not have the power to really be able to find an association with survival and DDR gene alterations, both in that study as well as this one. That's a great question. I think the limitation here is that, we used a certain set of criteria for sort of extreme responses or primary progressors in order to basically try to improve our sensitivity to capture certain genetic events that would be enriched within these two patient populations. And it is the same approach that was taken when identifying ERCC2 and other DDR gene alterations that were enriched in patients who had pathologic responses to neoadjuvant cisplatin-based chemotherapy. But in this setting, it's a little less well defined what a meaningful clinical response might be to platinum chemotherapy, in the metastatic space. Although primary progression on the first scan versus sort of partial response lasting 6 months or more, which is the definition that was used here, it's reasonable to use that. But the observations also with FRY, I think they really underscore that the in vitro models are great starting points to try to understand the function of specific proteins, both in the wild type as well as the altered setting. But ultimately, if these alterations are deemed targetable or in some fashion or other with an available drug or a novel one, it's going to take those clinical trials in patients that will really be able to provide the answer about whether they truly are biomarkers. Or not. And there are certainly many examples where retrospective analyses might identify a specific target or a genetic alteration as being a good biomarker, but then when we move it to the prospective space and into clinical trials, that's not always the case. Yeah, so in general, we wouldn't recommend doing routine DDR testing outside of a clinical trial setting at all. But next generation sequencing should be strongly considered in any patient with metastatic urothelial cancer, given that there are FDA-approved treatment options, specifically for patients with FGFR3 altered therapy. There's a drug, erdafitinib, available to them. And additionally, if the patient has a high tumor mutation burden, which actually there is an association between high TMB and the presence of a DDR gene alteration. If that patient hasn't received checkpoint blockade already, pembrolizumab has a tumor agnostic approval in patients with a TMB of greater than or equal to 10. And so, next generation sequencing is a good idea, not specifically geared towards doing it for DDR status definitions, but just in general, because it may provide opportunities for patients, both in terms of standard of care as well as clinical trials. So right now, the two main biomarker-directed strategies that are standard of care for patients with metastatic urothelial carcinoma, it's specifically in the setting where the disease has progressed already on first-line treatment, and those are erdafitinib for FGFR3 altered tumors and trastuzumab deruxtecan for HER2 3+ expressing tumors. And so I usually prioritize next-gen sequencing as well as HER2 staining for patients who have metastatic disease, and I try to do that as early as possible in their treatment course. So, for example, if they're receiving enfortumab vedotin and pembrolizumab, which is the sort of NCCN preferred option in the first line setting, try to get testing performed while they are on treatment with EV and pembrolizumab and before progression of disease has occurred, so that at the time of progression of disease, we have these potential options available for patients. And then, as I mentioned before, the next generation sequencing also really opens up options for clinical trials of biomarker-directed therapies. There are more of those that are starting to come out now, whether they're sort of newer FGFR3 directed therapies that might be better tolerated for patients, or others. We are starting to see this more of these trials opening up, and so it is a good idea to do NGS because right now we don't really have a standard of care in patients who have had progression of their disease on EV and pembrolizumab, outside of sort of the biomarker directed approach. And of course, there are certainly a good number of patients who don't have either an FGFR3 alteration, which is really found in about 20% of tumors, or HER2 3+ expression as well, which is probably also around maybe 15 to 20% of urothelial cancers. But outside of those two, there's a large group of patients for whom we don't have a standard of care. And so for them, doing something like NGS would be a good idea to try to identify some novel biomarkers for clinical trial approaches. Yeah, thank you. I think that overall, this study found that DNA damage response gene alterations, as well as the basal molecular subtype of bladder cancer, did not associate with response or improved sort of outcomes in terms of survival to either gemcitabine and cisplatin or gemcis and bevacizumab in patients with metastatic disease. And certainly these findings are different than what we see in the neoadjuvant space for probably the many different reasons, as we discussed. Um, but regardless, now the metastatic space has really kind of moved on beyond cisplatin-based chemotherapy, at least in the first line setting, where most of our patients are receiving that combination of enfortumab vedotin and pembrolizumab, EV plus pembro. We certainly need more in the way of biomarkers for EV pembro, which is not going away anytime soon. And being able to define who maybe doesn't need sort of a long-term protracted course of therapy and can avoid toxicities, and potentially where treatment could be de-escalated is an area of significant interest. In the neoadjuvant space, cisplatin-based chemotherapy currently is still a standard of care when given with durvalumab immunotherapy based on the Niagara trial. And it'll be very interesting to see, what specific biomarkers, either tumor intrinsic or host intrinsic, might really help us to define who would be most likely to benefit from this treatment option as well. Thank you.